Good afternoon. So we have had a good start. We have had three strong voices speaking, the chaplain, the director, as well as Moira, really highlighting about how important communication is, what is the need for it, why do we need to have these tender conversations. I mean, I remember even in the journey that I have been in palliative care, the terms that we have really changed. I mean, as is the concept of palliative care, we used to just focus mainly on initially on the dying population, cancer, and then now you encompass such a range of serious health related suffering, as well as even communication. I remember, it was just speaking about breaking bad news, very cliched, just speaking about, what you have to tell and how you have to tell. But now when I hear about the terms which have evolved from this, talking about, tender conversations, it's a real new experience for us too. I'm here to just highlight some important components, and I know that these are basic issues, I mean, aspects that all of you would know, but it is always good to remember, always good to again relearn and reiterate what we have learned, because communication is a process that we take, almost as a, as if it comes very naturally to us. We all communicate daily in our lives in different domains, but it is always helpful, like Moira pointed out, that to know the skills, to practice, to rehearse, and to get feedback, to get supervised so that you can do better and better. So it's always good to be aware, what am I doing? What am I talking? And to understand where you have missed something or where the gaps are. Because you do this every day, and every day is a learning process, and it is individualized, and each person comes to you with a different story, different experience, and you have to actually bring your skills together to cater to that person. So it's not very easy as well. It takes all your experience and skill and learning to attend to that person. So this is like a typical scene. And when I crossed the OP counter where people were getting registered to get the OP numbers, I was thinking, see, so this is what we see, isn't it? So many people, so many, now we have this mobile phones also ringing, so many distractions, so many interruptions. But everybody actually means well. We want to care for each other. The doctor is really very caring. He's saying, if I can be of any help, don't hesitate to ask. But nobody would ask him because he's looking so harassed, isn't it? Why do these happen? So I think it's always good to remind ourselves, are we going through the right process, the appropriate process for our own people? Because especially in India, not in the developed countries like UK, which is much more the system, like she was talking about the individualistic and the collective society, isn't it? Similarly, even the models that people use for communication has also changed. But in a country like India, because of the society, because of the unit that we live in, the family plays such an important role. And also the doctor is also perceived as and almost like God, isn't it? We see it's almost, it has the good and bad in it. I mean, God will save us, will cure us, but also that you are so scared, you don't want to, break the rules or ask difficult questions or say something which is inappropriate. So when you go to a hospital, you're actually, very, very, it's scary for a person who's just asked to go to one room number, and so they just follow the instructions but do not ask questions or do not bring in their innermost fears. So it is for us to and find out what is beneath those questions that they ask. So this model is actually one of the commonest models that is followed, that is the paternist model. You would have heard about this. It's like a father treating their children, like telling what to do and what not to do. So usually doctors, as doctors or even carers, we tell our patients what to do. It's in good faith and intention. But what happens is it doesn't become a mutually agreed agenda. It's about telling them what to do. So, as experts, we always try to give them information, and the patients and their family passively receives this information. They don't ask you back. They think that following this is enough, and the decision is always made by us who are giving this care. We don't actually involve them into the decision making. So, how can we do that? And we also have these unconscious mechanisms in ourselves. Moira and the director mentioned how when we become helpless, often these issues in communication comes up because we do not know how to manage, or we do not know how to, maneuver a way behind that barrier which comes up, or the block. And we have our own mechanisms where we bring this distance between ourselves and the patient or the family members. One common is labeling. We always say, like, said himself, he's a number or he's a case. As medical students itself, we discuss as that patient with that splenic mass or a renal mass, go and palpate that, or that, diastolic murmur. So we always refer to people with the symptoms or signs that we want to know, not as people. And even as students, when we go to the bedsides, we are so focused on, seeing what they have, we forget that there is a person behind. So that's kind of a biomedical model that we follow, which we have to actually expand to actually consider the person who is giving us that opportunity to learn and understand. So, and also we say, he's a difficult person, she's a cancer patient, that paralyzed patient. So this labeling, this itself can create a distance between us and the patient. There is also this tendency for us not to inquire beyond the physical aspects. We are very comfortable, we are trained to identify symptoms, give medications, treat them, but we never ask, how are you feeling? Have you been sleeping? How have you been coping? The questions beyond the physical symptoms have always been to the minimum because we think the priority is to manage the physical symptoms. So, how do we ask that? Sometimes when we take this, especially happens if we are reviewing a person and we are taking ward rounds, we ask definite questions. It's almost a leading question. That means you are actually expecting the answers give you. So you're saying your pain is better, isn't it? The person naturally says yes. So you're not asking how is your pain or how have you been or how are you feeling, which is an open question. You're asking a leading question. Or you're asking a closed question where a person has an chance only to say yes or no. Did you sleep well? Or you're not asking them how have you been, how has your night, how did you spend your night? So it's not an open question again. So these two questions, of course, when we take a history, we might ask a closed question or leading question in between, but not as part of starting or inquiring or opening, the narrative process. Don't worry. Anybody in your position will feel upset. We have our own helplessness. We want to normalize the situation. We want to reassure them. So we try saying this, anyone in this situation would do this. I can understand. This kind of normalizing, any person can feel that, my pain is my pain. It's not anybody else's. What I suffer, you will not understand. So that is what this person is left with when you say that in your position anybody will feel upset. So I would think that no, I'm not bothered about anybody else. I'm worried about my own, worried about my own pain, what I am going through. Why should I worry about anybody else? So that is where these things that you do not understand, and that again puts a distance. This is what Moira said. Said, don't worry. This is probably one of the commonest responses that anybody and everybody has. And our intention is fair. We want to just protect them. We don't want them to be sad. We want to just, but what happens is when you say don't worry, it's a very transient momentary relief that you give them. Because when you move away from them or when you go out of the room, he's left with the same set of problems that he has. And he's thinking that, what am I going to do with this again? So don't worry really doesn't bring a lasting change to the person's suffering or distress. So we need to find better ways of empathizing, better ways of responding so that the person feels reassured or the suffering, the distress really gets lesser. This is one way that we also, we use. Actually, sometimes we use it inappropriately because when the person is really having a distressed time, we being unusually pleasant or cheerful or, making, the intention things lighter, more, cheerful. And we go in and, we say, sometimes we even crack a joke. We can, during ward rounds, we can say something which is very funny, but it might not be suited to the occasion at all. So we have to be very, very careful in the way we are responding and we make these comments. I have seen this happen, and it's not often the most ideal approach to use humor in all occasions. Isn't this very common, especially for the younger doctors and nurses? It's always, easy to shrug away our responsibility and say that Dr. So and so will come, he will take care of you. Or in our setting, remember the paternalistic model I said, it happens because we expect the doctor to take responsibility for everything. The nurse's role is to just give the prescribed medications. But it is not so. Like Moira said, nurses spend most time with the patients and the families. When you're cleaning up, when you are, talking to them in the night times in the ward, you sit with them, you talk to them, you change their clothes, you make their beds. They see you more than the doctors who come for ward rounds and come for emergencies. So I think the nurses, anybody, is as equally important to take this responsibility of sharing information, conversing or having these tender conversations with people who are suffering. So to say that, you should go to, and talk to the doctor, or sometimes between specialties, when you're in a hospital, it's easy for some specialty to say that go and talk to the other person, he's treating you, go and talk to him, rather than saying that, let me see how I can help you. I know that I do not know details about it, but I will help you. I'll find out a way to answer your question. So the same information can be given in very, very different way, which is actually helping the person rather than just passing the buck. Is this familiar? I think all of us use this inadvertently when we see people, when we ask them questions, we say all this. Even simple, very common disorders, even like diabetes or tuberculosis, some people do not know it. So we should be very, very aware of what the language is, what the the setting is, and what people actually refer that illness as, and use that, or take help and talk about it, rather than using very father has cirrhosis and on top of that he has developed septicemia. I have seen people say that you have stage 4 cancer with metastasis. What is a person going to understand from that? But it's very common, and then when the next day when they come and questions, we will accuse them or we will label them saying that I did this all yesterday and they're asking me the same questions again, because we assume that the communication has happened. We are under an illusion that we have completed the communication process. In fact, it is not so. So we hear this often, isn't it? You have lost. So like saying that, when something happens in India, we say, look at what happened in Iraq or what happened in now you can say Ukraine, so many conflicts are happening elsewhere. So you think that then our suffering becomes lesser. Is it so? Do you think so? It doesn't matter what is happening around you, what happens within you, what is happening to you or your dear ones. That makes sense to that person. That is the meaning of for that person. We cannot compare and say that, see, you are old enough, that is a child having cancer, you should see that and be happy that you have had it only now. These are the ways sometimes people, try to give solace. But this is again not a way of giving appropriate relief to the person. So this is just a cartoon to show you how, we can actually ask them that, you must clearly explain your problem when they are not actually in the most comfortable situation, either physically or, in terms of how they have been, trapped into this situation where they are forced to be in front of you, but not given the comfort of really having a natural environment to speak to. And also the barriers that you can see, in terms of how it's seated and all those things. There are many barriers to communication. Often the most common that people say when we discuss in workshops like this is they say that I don't have the time. And I can understand that when you say that you don't have the time, because time management is really difficult, especially when you have such a large number of people coming to the OPD, or in the, you have full wards. How do you spend 1 hour with each person? Is it possible? So people generally then say that I don't have the time to have such long conversations with people. But do we really need 1 hour with everyone? Actually, we don't need 1 hour with everyone. Actually, it's only a percentage of these people who would need a longer time to discuss issues. Most people we are able to manage within the time frame that we can. It's only a handful of people that would need more time from you. And also, it's about asking or responding with the appropriate responses in the given time that you have. So when we started palliative care in photographs where the whole room would be with stretchers and beds with people. So how people would ask us, how do you make this conversation private? Even in the small space that you have in a busy OPD, how do you make this? How do you manage time? So it's about how you can adapt or use that setting to maintain the privacy as far as possible with your own body gestures, leaning forward to them, being close to them, and making that conversation as private as possible. So that's how you use time also. With the time that is available, try to make the most of it by asking the most appropriate questions, asking them, understanding their responses, listening to them, and then responding back. And also, like I said before, thinking that these issues are not important. Only the physical aspects, the pain. Even in palliative care, when we talk about pain, where does this communication or the distress regarding the psychological or spiritual suffering, how can we have an hierarchy of suffering? Everything is equally important, isn't it? What if they ask difficult questions? If they ask me, like Catherine, she said, am I going to die? What do you do when people ask such questions? I'll feel very helpless, won't I? I won't have the answer. What if I don't have the answer? So the easiest way to say is that they will not understand. They will not understand the issues that we are going to discuss with them. So if they are not going to understand what their illness is, the technical or the medical aspects of it, the best way is not to talk about it and just say, don't worry, we will take care of it. So that's how we think. Again, I want to emphasize that the intention behind this is not that you want to cause distress. It's only our own helplessness and our own lack of experience and lack of training that we tend to use such inappropriate responses. Like I said before, being selective, you assume a lot of things. When the patient says, Doctor, I'm so worried, I can't sleep properly, I also have pain in the back, the doctor immediately asks, tell me about the pain, because that is the safest aspect. Because I can manage the pain, I'm trained to use analgesics. That's the easiest thing I can do to reduce your suffering. So let me do that. But I do not ask about why he says he was so worried or why he's not able to sleep. I just assume that he's not able to sleep because of his pain, and that is why he is worried. I assume. So we assume a lot. So rather than assuming, it's always better to ask why, what, how to them. I mean, our teacher, Dr. Rajgopal, said that actually you don't have to have any solutions. You just keep asking why, how, what, and the conversation itself will facilitate that process of giving them answers. You don't have to really have ready-made solutions for people. How do I reveal a bad diagnosis to the patient? This is one difficult scenario. The family does not want me to reveal it to the patient. I think we'll have some role play also. Other important is when the person, other situations are when patients or the family member starts showing emotional reactions, like suppose somebody starts crying. How do you manage crying? Or somebody gets really angry. I remember when I started off in palliative care, there was a woman with advanced breast cancer, and then she also developed lung metastasis. And because she was coming continuously for her management of her symptoms, we had a good rapport. And then in one of such transactions, she asked, "What is happening to me? I'm not able to breathe properly." But by the time we just geared up to really attend to that question, just came and stood between her and me, physically obstructing me, getting angry for even thinking about answering that question. That is how people react sometimes. How do you manage such volatile or such very, vulnerable kind of situations? So that is also one important aspect of communication. I'm sure that this is very familiar, interruptions. We interrupt a lot, don't we, when a person says something, because we interrupt them because we want to get as much as information as possible. So how often do we interrupt to get the information we want? And it's also good to reflect and think that, do I like to be interrupted when I'm saying something? So when you are relating something or giving information, if you get interrupted often, how would you like it? So, what do we want to achieve when we say that we want to have a good conversations? Like, which was repeated quite often by Moira also, being present. So your presence is absolutely necessary during the communication. So that means that you have to be prepared. You cannot just say that, yes, I will just talk to you in the corridor. So make time for it, prepare yourself, pay attention, so that there are no interruptions. Switch off your phone, tell your staff not to call you, or unless there is an emergency, and have this listening carefully. I'll talk about active listening and the components of compassion that Moira had highlighted so very well, and being empathetic. So what is active listening? Again, I want to quote Dr. Raju Gopal. He used to say that, you have, when you hear through one ear, use the organ in between before you let out through your mouth, or you just leave without responding. This is very important, because active listening is not only hearing, that sensory process, but also understanding with your own experience and then responding to that statement of that patient. So that is very important. And what are the mechanisms by which we can practice active listening? Show that we are hearing by verbal and non-verbal means. I'll just go through the components. So encourage talking, ask them why, like I said, why, what, how. So that's very important. Asking open questions in the beginning. How are you feeling? I'll just give you examples further. Repeat or echo what they're saying. When they say something and they pause, just repeat what they're saying in the same way that they have given you the information. It's the same way, same words that the people use, echo. Because you can also use something called reiteration or reframing, which is giving them back the information they gave us by using your own language. So again, you're giving them the feeling that you have listened to them. So the main intention of this process is that you are telling them that I have listened to you, I have understood what you are saying, and is that correct? Do you agree with what I am telling you? Reflect your feelings. Ask, I can see that you're very angry, or I can see that you're very upset. Do you want to talk more about it? That's a good way of getting them deeper into the conversation, as well as to explore further. What I meant when I meant reframing, that is also said as paraphrasing. That is, you use your own language, your own words to tell them what is happening. Tolerate silence. I think that's very important. Often people take time in between, and then they pause for some seconds, or sometimes even for a minute, and then they carry on. But we do not have the patience, because we are aware of the time constraint that we have. We are very busy, aren't we? And then we also, we want to quick information. So important components, like I said, is the space, time, ourselves, us, me and you, and empathy. So what we want, or be the most appropriate, will be space for the patient and the family, privacy. But the reality is that we often have cramped, uncomfortable, lack of private spaces. Like I talked about time, we always want a reflective conversation, mutual agreement, privacy. But in reality, we have to do the best we can with the time we actually have that is available. There is a study which says that patients were interrupted 11 seconds after beginning to talk. So we should learn to allow silence and respect silence as well. About ourselves, how am I feeling? How is my emotional state? Am I physically comfortable. So take a moment to settle down and prepare yourself for conversations. That's very important. Empathy, often the cliched term that is the definition is that putting yourself in another's shoes. But I think it's a capacity for tuning into another. Only when you experience suffering can you really understand what the other person has gone through. So look into your experiences, what you have gone through, and understand that that person is actually going through similar suffering. Express empathy by, I'm sorry to hear that you're not well. You must be feeling very sad about it. How do you manage in such troubles? Just expressing empathy. Facilitating good conversations. We use only 7% of our time as verbal. Mostly we use non-verbal. Yeah, our body language, our gestures, our eye contact, the touch. If we can touch culturally appropriately, all that is very important. Our tone, the tone of our voice is the paraverbal. How we say it is also very important. So what we say is not actually the most important thing. How we say it and our own non-verbal mechanisms are very important in facilitating good communication. So think about these. How fast or gently am I moving towards my patient? How is my posture when I speak to them? How am I holding my head, my hands? Am I leaning into the patient quickly, or can I do that slower to give them see me coming? At what pace am I withdrawing from the patient, abrupt or gently? Am I giving them enough time to realize that I'm moving away? So use these, this is for your self-reflection. Reflect on your communication process, and then that will help you improve and improvise. Gentle, open questions of how are you? Tell me what is happening. What is troubling you? Can you tell me more to understand more about your illness? Silence, like I said before. So it's again a very good interpretation of silence. When people are silent, there is a lot of thinking going on. Be aware of it. Because most of us are busy talking to ourselves to even contemplate what might be vivid and apparent. Should we ever learn to shut up? Check the fears once again gently. Is it physical, the pain, the social, loneliness, isolation? For emotional, is there anxiety? Is there sadness, profound sadness? Where will I go when I die? Will I be punished? These are the thoughts that would be beneath difficult questions or difficult statements by the patient or the family. This is an important tool again. Nurse protocol, tool to explore, like naming the emotions, understanding the emotion, respect, support, and explore further. Tell me more about your concerns. There are difficult situations. We will be talking about it in our role play as well. So someone saying that, please tell me if I can go back to work again. This pain is unbearable. There is no one else to bring in money for daily expenses. My children will starve. So how do you answer such questions? You can't give them a blunt response. So you need to take time, spend time with them to understand what is beneath this. What do they actually want to know? So try to find out, align yourself, in that process. Moira had brought in that tool of spikes. It's know what the patient and the family already know. Ask them what do they know about the illness. Align yourself and know how much they want to know. Respect the local culture and the tradition and the language. Take small steps, like we say that give the information piecemeal. Give them small bits of information in the language that they understand. Speak slowly and repeat if needed, because they will ask you again. You might have to repeat again and again, because if you are in a difficult situation, you are always in a daze. And sometimes you cannot, it's very overwhelming. You cannot filter all the information into your mind. So be ready to say it again and again. Another difficult situation is, please do not tell him about the cancer. He will not be able to bear it. This is collusion where, the family being very protective, do not want their loved one to, go into a shock or jump into the well, or, they always think that if they get bad news, they will do something very harmful to themselves. So we have to take time again, to spend time with them, to align yourself, to understand that the family is actually protecting. So you tell them that we are actually a team working together to help the patient, not that I am on the other side and you're on the other side. We are all working together and we'll do this together. So include them into the process, the family, and tell them that we are not going to just give them the bad news on their face. We are going to according to the needs. It should be a patient-led agenda. Follow the cues of the patient, and that should determine what is being said. So it is not about what I want. I have to tell them there's a stage 4 cancer or something like that. It's about what they really want, and then catering the information to their needs, respecting the emotions, understanding, giving pauses, and then also tolerating the silence. So when you sense there is sadness, simply look with kindness and gently touch your heart with one hand. Be present, don't interrupt. Be witness to the sadness. Healing comes when people feel seen and heard. I think listening, active listening, is very, very important. So, like I said, acknowledge the concerns of the relatives. Collusion is generally an act of love. The relatives often argue that they know the patient better. So, explore the reasons. Check the cost to the colluder. What happens when you do not give proper information to the patient, to the family, as well as to us? What is the cost of that? Negotiate the access. Promise not to give unwanted information, but always keep it open for further sessions. Robert Buckman, a medical oncologist from US, we had books for him for breaking principles of communication. Very good to learn for beginning in communication skills. He said that an expert in breaking bad news is not someone who gets it right every time. He or she is merely someone who gets it wrong less often and who's less flustered when things do not go smoothly. If we do it badly, they may never forgive us. If we do it well, they may never forget us. So it's very important. Often, a family remembers you not for diagnosing or giving the right medications, but for you being present with them and giving them compassion. Thank you so much.